So clinical features, talked about that also, but we'll just go through. So say usually this patient, because you'd have that congestion in the lungs, they tend to have difficulty in breathing. One other classic thing is when they lie down flat, they find it very difficult to breathe. So they'll prefer to use about 3 or 4 pillows, or we call it autopnea. Then sometimes whilst lying down, they quickly get out of bed and then they would have to rush to the window to get in some air, okay, which you call paroxysmal nocturnal dyspnea. It's because they get a sudden shortness of breath at night when they start feeling all comfortable and all that. So they just wake up and then rush to the bed to get some air. So when you're taking a history of a patient you think would have heart failure, you'd have to ask, would you have any difficulty in breathing? That's if you're seen at the OPD, because definitely at the ER, they'll come to you with difficulty in breathing. And then they sweat a lot because of the whole difficulty in breathing, and then the struggle to be able to breathe and all that. Then they cough. When they cough, it's usually pinkish, right? Because you have extravasation of fluid. It would usually contain some red blood cells that has broken down. So when they cough, it comes out as that. It looks a little bit pinkish because of the red blood cells in there. Then there's difficulty in breathing. So they would have cyanosis as well. Okay. So you check their lips and then you realize that it looks blue or dark, depending on the color shades. And then they have the palpitations as well, because the heart has to compensate. Once it's failing, you need the heart rate to go up in order to compensate, so the heart beats a bit faster. In a case where you have anything causing an enlargement in your left atrium, okay, because once you have an obstruction there, eventually the left atrium also becomes enlarged. And there's a nerve called recurrent laryngeal nerve, which lies close to the left atrium. This recurrent laryngeal nerve is responsible for supplying your throat area, I mean your vocal cord area and all that, so that your voice won't be very hoarse. So once your recurrent laryngeal nerve is gone, is obstructed, or maybe during surgery, someone cuts it. Usually when you're going to have thyroid surgery, that's one of the things we look out for, so that we don't cut your recurrent laryngeal nerve, because you can go and have the surgery and afterwards, when you come back, you lose your voice because we've cut your recurrent laryngeal nerve. When the recurrent laryngeal nerve is compressed because the atrium has become bigger because of the pressures there, the patient will come to you and the voice will be a bit hoarse. Okay, so you look out for all that. Usually with profuse diaphoresis, or let's say in the case of TB where we said night sweat, we are looking at temperatures and all that. Most of the disease conditions that would cause an increase in your metabolic activity would eventually lead to you having some form of profuse sweat. So the TB, apart from the fact that the infection and the temperatures would give you that night sweat, because of the increased metabolic demand, the Mycobacterium tuberculosis also has like some form of increased metabolic demand. So they stress your system, and with your system trying to compensate, you end up sweating a lot. It would just be like you've run like 100-meter race and then you are sweating and all that, because the microorganisms does that. Most disease processes have the effect to stress your metabolic system. And once that happens, definitely you are going to sweat a lot. Okay. So cancers can do that. TB does that. Heart failure would also do that. Okay. So that's where the sweating would usually come in. Usually when you're examining and you check their pulse, you realize that their pulse are very high. They have a very, very raised pulse. They also have respiratory rates, in this case too, would be very high as well. And then most of the time the BPs go up, all in the face of trying to compensate for whatever is happening. But when you have another complication happening, or there's a rupture or something of the myocardium, then it means it will start as BP going up, but then eventually the BP will drop, okay, as we've talked about. Once you have poor oxygenation, it gets to a point where you become confused and agitated because oxygen isn't getting to your brain. Then full clammy extremities, okay, just like you are going into shock. And sometimes you listen to the chest, and then because you got a fluid stuck in there, you'd hear crepitations. The crepitations in this case will be fine, not cause like the one you get in TB and pneumonia and all that. You're going to hear fine crepitations when you are dealing with heart failure, pulmonary edema. Okay. Your differential diagnosis. So you have a patient coming to you with difficulty in breathing. We'll ask you that what's your differential. So you should be able to tell us that, all right, it could be asthma. It could have an acute respiratory distress syndrome. It could be a pneumonia. It could be a COPD, which emphysema is part. So basically, yeah, that's your differential diagnosis there. And then investigations, we've talked about that. Always full blood counts is very essential. And once you mention full blood counts, we'll ask you why you're doing your full blood count. So you should be able to tell us, okay, I'm doing my full blood counts because uncheck HB. Why do you want to check HB? One of the reasons why I would want to check HB is that anemia is one of the main causes as well. If it's very bad for heart failure, once you have anemia, you can actually develop heart failure. So you'd want to be sure HB is okay. Okay. There's a pulmonary edema we are talking about here. Patients can't breathe. It could actually be an infective process. Okay. So your WBC will tell you that, why can't this patient breathe? Does it mean the patient has a pneumonia? And that's why you need your full blood count, because your WBC will tell us. Okay. So we tend to look out for all that. Platelets, very, very essential. When you check and your platelets level, could it be that the patient has some condition where platelets are so high, which we call thrombocytosis, and so the patient is clotting? If that's the case, as the patient's clotted in the lung, are we dealing with a pulmonary embolism? All those things come in. So your full blood count is not just for fancy stuff, but there should be a reason to your full blood count. Then we check your electrolytes, okay? We check your blood urea and then creatinine. We do a pulse oximetry just to check your SpO2. We can do your ABGs to check partial pressures of oxygen and carbon dioxide to see how bad the condition is going. Obviously, if the condition is getting worse, your partial pressure of carbon dioxide will go up, okay, in the blood, and or partial pressure of oxygen would rather drop. So we take a look at all that. Then ECG is key, because once we are talking about cardiogenic, we need to know what's happening. So we said that you can have ST elevation, non-ST elevation, all that the ECG will tell you. Your chest X-ray, remember in class we projected a chest X-ray of pulmonary edema, and we said we go with A, B, C, D, E. Usually you say A, alveolar edema, B, Kelly B lines, okay, which is because of fluid congestion in the lungs. Then C, the heart becomes bigger, or we call cardiomegaly. Then D, there's a displacement of your pulmonary vessels. Because of the edema, it pushes your pulmonary vessels upwards, okay? So there's a displacement of your pulmonary vessels. And then E is effusion, okay? So those are the features of pulmonary edema, A, B, C, D, and E. So we shouldn't forget them. Management, always check the airway, you check the breathing, you check the circulation, okay? So in this case, you'd want to open the patient's mouth and check if patient has any secretions or any obstruction there, because patient has come and is breathless. You are managing and taking the history at the same time. You can't afford to sit and be taking history and then afterwards you come and manage the patient. So whilst you are managing the patient, you are talking to the relative. What happened? How did this come about? So then you're checking the airway. Your colleague is setting a line. If it's just you, then you are checking the airway, setting a line. Your nurse is around trying to get oxygen and all that intact. Then you start your oxygenation. The reason why you need to check the airway is usually when they come to you at the ER, you are not going to intubate. Intubation means that for you are going to straight away put an endotracheal tube down the patient's trachea and then connect to an oxygen. No, you are going to start with your usual intranasal oxygen, and then if it doesn't improve, that's where the anesthetist will come in and they will intubate. If you don't check the airway and you just put your intranasal oxygen, the oxygen won't get to the lungs, because for all you know, the patient has got a lot of secretions there going down before getting to the trachea. There's secretions, or maybe the patient has swallowed a foreign body or something. You don't know. So you always need to check the airway, okay? Of course, if you are dealing with a pulmonary edema, then you won't have that. But let's say you have a case where they rush a patient who has difficulty in breathing. Always assess the airway and be sure there's no foreign body in the airway before you give your oxygen. Otherwise, you'll be giving oxygen and SpO2 will still be low, okay? And then whilst you're giving the oxygen, you're checking the patient's breathing pattern. Your line is in there just to assess circulation. Circulation here goes two ways. If, let's say, as we talked about, you're dealing with a hypovolemic shock, then you give your fluids. Okay, you are doing whatever you are doing here is to maintain the circulation. So if it's a cardiogenic shock, you want to maintain the circulation. So what do? You're going to give a medication that is going to help the heart contract more, which we call inotropic agent. So when you look at the last bullets, you see some medications there, dobutamine, dopamine, noradrenaline. They help increase the contractility of the heart. So for cardiogenic shock, that is what you give. You stay away from IV fluids because you can tip the patient into a very, very, very bad pulmonary edema. You made a pulmonary edema even worse, and you drown your patient. So your aim is rather supposed to get fluid out of the patient rather than what? Pump fluid into the patient. So how do we get fluid out of the patient? And that's where our diuretic comes into. Furosemide, you can give between 80 mg to 200. In fact, some people can even give 240 mg because furosemide has a very wide therapeutic index. You can go high, high, high. So sometimes even 320 in a day, and you won't have any complications with the patient. So you give according to how bad the pulmonary edema is, and that will be dependent on when you listen to the chest. So whilst you are giving your furosemide, you keep assessing the patient's chest for crepitation. Okay. So for me, ideally, I give about 80 to 120 milligrams start, and then 80 milligrams every 8 hours. Okay, that's how I give. And some people can also just go straight and then give maybe 160 milligrams start and then 88 hourly. It depends on how bad it is, and it depends on the specialist you are working with. Sometimes when it comes as an emergency and you are pressed, we can go as high as 200 mg start because we want to save the patient. Okay, you are desperate. So we know that 200 milligrams won't kill your patient, so you give it, right? Now, the other aim is you want to reduce the congestion in the lungs. You want to do that also by reducing the amount of blood coming to the heart, because the more blood coming to the heart, the more it would eventually get to the lung for oxygenation and then return back to the heart. So two things, preload and afterload. Preload has to do with the amount of blood you have collected in the heart before the heart was contract. Okay, so that's preload. And then the afterload is what? The amount of blood or the pressure over there that's the heart is supposed to what? Pump against. So we want to decrease the preload so that we'll reduce the amount of blood coming into the heart so that we can make the work of the heart easier. Okay, so we'll decrease the preload, and also we want to decrease the afterload, meaning we want to reduce the pressure in the systemic circulation so that the heart can be able to pump easily against the pressure in the aorta and then push more blood into circulation rather than pushing the blood into the pulmonary vasculature. Because if the afterload is high, then it means your heart would have to do more work. The left ventricle have to do more work to push against that pressure. And in so doing, it would get weaker and weaker, and then blood will get backflow into your pulmonary veins. Okay. So how do we decrease the preload? We'll give you something that would open your blood vessels so that it will cause the blood to stay in the blood vessels and reduce the amount which is getting to the heart. So we'll give you a vessel dilator, and nitrates are vasodilators. So we can give you that. We can give you hydralazine, which is also a vasodilator. It opens it up for you. Okay, so it opens your peripheral vessels up, and your peripheral vessels rather become congested rather than your lungs becoming congested. We would rather have you developing edema in the periphery than you developing edema in the lungs, because it's the edema in the lungs that will kill you. So it would increase your preload, and hence there will rather be congestion of fluid in the periphery. Okay, that's what we'll do. And then we'll decrease, so we'll decrease your preload, and then what? We'll decrease your afterload as well. How do we decrease the afterload? We'll give you ACIs and ARBs. And ACIs and ARBs basically come in and prevent your body from making aldosterone. And we know what aldosterone does. Aldosterone has the ability to cause salt and water retention. So that is going to increase the pressures in the blood vessel, and hence it would increase your preload. So it increases the pressure at which your left ventricle should pump again. So your ACI, ARBs would reduce the afterload. Okay. Any questions before we go on with the last few slides? Any questions on the management before we go on?
Please, I have a question.
Yes, please, Jenta. Yes, please.
You said we give the furosemide.
Yeah.
That is the diuretic. And
yes,
are we also trying to inhibit the aldosterone, since if we are trying, furosemide is a diuretic, will make us lose water. So why is it that
water?
Yeah, working it again to reduce by giving the
Yes. So it's good that we need a balance. Okay, so maybe someone will say, okay, whilst you are giving your loop diuretic or your furosemide and you are losing fluid, you should rather aim at maintaining a balance. So then you shouldn't block the aldosterone so that there will be salt and water retention. But then that will mean that you are doing COS90. It will mean that you are getting rid of fluid and at the same time causing how do you call it? At the same time, causing your aldosterone to also function by maintaining salt and water reabsorption. We don't want that. The focus here is that the patient is actually, there's an emergency, patient is dying. So our focus is to relieve the patient of the edema. So any procedure that we need to do, because at this point, we don't need fluid in the patient's lungs. Any procedure that we need to, any strategy we need to use to reduce secretions in the patient would go for it. Okay, so you are giving your diuretic because you want to get rid of the fluid from the lung. That's one, that's good. But then mind you, we said this is a cardiogenic cause. So the problem of the pulmonary edema is from what? The heart. The pulmonary edema didn't just arise on its own in the lungs. It's arising from the heart. Why is it arising from the heart? It's arising from the heart because the heart has failed in its function to act as a pump. So it's pumping, but then the pumping is ineffective. Okay, so if the pumping was effective, the blood coming to the heart, all this blood will be pumped into circulation without it going back into the pulmonary vessels. But now the heart's function has become depressed, is unable to function as a pump. So our aim is to help the heart and make the heart's work easier. Okay, how do we do that? Because now the heart is struggling to pump out blood that is coming to it. Why don't we reduce the amount of blood that is coming to it so that it will make the work easier for the heart? That's one, and that's the decreasing preload. So you are going to give the vasodilators there to decrease the amount of blood coming in. Now to your question, after we decrease this preload, why don't we also make it easier for the heart to be able to pump the reduced amount of blood that we are now getting into it? Why don't we make it easier for it to be able to pump it into circulation? So how do we do that? let's give something that will reduce the afterload so that the pressures in the periphery would reduce. Because if the pressures in the periphery is high, and you're even reducing the amount of blood coming to the heart will still have to struggle to pump against the pressures in the periphery to eject that reduced amount of blood that it now has. Okay, so we give your ARB ACI to inhibit action of aldosterone. Once aldosterone's action is inhibited, you are not going to have salt and water retention. And that means that the pressures in the peripheral vessels will go down. And once the pressures in the peripheral vessels go down, it gives the heart the opportunity to pump easily into circulation, and everybody is happy. So there's no pressure, increased pressure that the heart has to pump against now. Because if there's an increased pressure, the heart will still try pumping. And because there's an increased pressure, some of the blood will still backflow into your pulmonary vein. Once you remove that pressure barrier from there by inhibiting the action of aldosterone, the heart is able to pump the reduced preload that it now has into the circulation, and then everybody's happy. So that's why we give it. So our focus is to, one, reduce the secretions in the lung, the edema in the lung, and two, make the work of the heart easier so that the heart can be able to pump blood into the circulation, the systemic circulation, rather than backflowing into the pulmonary circulation. Chief, are you okay, please? Or you want me to take something else?
Thank you, sir. Thank you.
All right, okay. You're welcome.
My line even dropped, but I guess I get to know.
Pardon?
I said I get you now. It's okay. It's clear.
All right, okay. Sure. Thank you. So the other last 2-3 slides focuses on non-cardiogenic causes of pulmonary edema. So there are, as I said, the other medical conditions that can also lead to pulmonary edema. Okay. You remember that if we scroll up and get to the pathophysiology, we see something about there are other causes there. You have a negative in interstitial pressure. You have a disruption of the endothelial barrier. There are so many other causes that can lead to edema. If you have a patient who they rush the patient to you, they tell you the patient was on the 6th floor and the patient basically fell, and now the patient has become paralyzed and at the same time can't breathe. You know that this is trauma. And the reason why the patient is paralyzed is because the nerves have become involved. Basically, the patient has probably ruptured, broken the vertebral column or transected the spinal cord at a certain level. Okay, so the patient will become paralyzed. Know that the central nervous system, for one of its main function is vasomotor control. All right, okay. So vasomotor control is very, very essential. You have blood vessel. You have your blood vessels there, and then you want to control how the blood vessels contract, relax, and all that. So vasoconstriction, vasodilatation, all of that, the nervous system has a role to play in that. So when you develop some form of trauma which affects your nervous system, that sort of vasomotor control is lost, okay? And when the vasomotor control is lost, it means the maintaining the caliber of your vessels becomes an issue. So you have a patient who has a trauma and has a neurogenic complication. Because of the loss of vasomotor control, the blood vessels will basically become vasodilated in a way. You have a lot of blood pooling in these blood vessels, and once you have pooling in a certain place, there's an increased pressure there. So there will be increased hydrostatic pressure there, and hence you are going to have leaking of fluid from the intravascular compartment to the extravascular compartment of the lung. So once a patient experiences some trauma, and then the spinal cord and all that becomes involved, the patient is now at risk of developing a pulmonary edema. So basically, these patients will come, you take a history, patient doesn't have any history of anything cardiac, young man, strong, fit, maybe a laborer working on some sixth floor, falls, and then comes to you with difficulty in breathing. Then straightforward, you know, this is a pulmonary edema, but this pulmonary edema is secondary to what? A neurogenic cause, okay? So the main management here is supportive. What you do is you have to support the patient. And how do you support the patient? So you admit, you make sure that your patient is well positioned in bed, and then you are giving oxygen. And at the same time, you are treating the underlying neurological condition. So if maybe it's a transected spinal cord, you call your neurosurgeons, they are getting ready to take the patient to theater to try and sort the issue out. So the management here is managing the underlying cause and then supporting the patient through the pulmonary edema phase. Okay. So there's also what we call high altitude pulmonary edema. I mean, P is usually pulmonary embolism, but for the sake of this slide, we are using pulmonary edema. So, you know, usually when you have people, you hear stories of people climbing to the highest point of Mount Everest and then they die up there and all that. Okay. But then they still feel fulfilled because they think they've achieved what they wanted to do in life. So once you go to a certain limit, what happens is that the pressures over there would cause a change in the pressures in your lungs. Okay. So in this case, it's all about pressures. So the pressure at that high altitude causes a change in the pressure of your lungs. And then in the end, you are going to have an increased hydrostatic pressure there building up in the lungs. Then you are going to have fluid extravasating into the extravascular compartment. Then you develop a pulmonary edema. So one classic thing is when people are in a plane and they're high up there, and then all of a sudden part of the plane breaks, and then everybody is panicking and all that. You realize when you see in movies, you usually have some oxygen cap falling. Why it's this way is once you are high up there, it's a different altitude. So the pressure up there is different from your usual pressure down here. So once there's a breach in the aircraft, we need to balance your pulmonary pressures and the pressure up there. So you need high flow oxygen. Okay, and that's why you got oxygen up there, so that just in case there's anything, you quickly put it on to readjust and all that. Otherwise, before the plane crashes, everybody in the plane will die because they would one way or the other develop a pulmonary edema due to the high altitude. Usually once a patient experiences this, okay, what you have to do is you have to bring the patient down from the high altitude, and then we give our oxygen, and then we put the patient on nifedipine. Nifedipine, we know, is a calcium channel blocker, and calcium channel blockers are able to act by causing some form of vasodilatation as well. Okay, so in the end, one way or the other, once we usually put the patient on the nifedipine, through some funny means, is able to help with the whole breathing process, okay, whilst you still give your patients oxygen. Usually in 48 hours, it tends to resolve by its own. Then you have re-expansion pulmonary edema. So that's the last one we'll be talking about. So sometimes you have a patient coming to you who has a lung collapse, okay. Let's say the patient has a stab, and then this stab has led to collapse of the lung. So air has leaked out of the lung. Once this happened, the lung, when you take an X-ray, the lung would actually look smaller. And then in the pleural space, or the pleura which is around the lung, rather looks bigger. So a classic X-ray will show you, ideally, when you see an X-ray of the lung, you see you're supposed to see a black field with what lung markings, and lung markings would usually be a bit whiter. Okay, in this case, you are going to see a very small area with lung markings, and that's the lung. And around it, you're going to see a very large area looking all black, and that is the air in the pleural space. Once that happens, we say the patient has developed what? A pneumothorax. How do we manage a pneumothorax? We have to put like a sort of a puncture there and then get the air coming out. Okay, so we drain, and in draining, usually once you put the tube, the chest tube there, and then you have the air coming out, there's a rapid change in pressure in the lung because this lung has collapsed. All of a sudden, you've drained it. Patient has taken a deep breathing, and then the lung has what? Inflated again. So there's a rapid change in pressure in the pulmonary vasculature, and this rapid change in pressure eventually leading to an increased pressure would cause fluid to move from the intravascular compartment to the extravascular compartment, and hence an edema would develop. So the patient came with a pneumothorax, you drain, and now your patient will have what? A pulmonary edema. So that is re-expansion pulmonary edema. So usually once we are getting the air out, we have to be more careful, and we have to think of a possibility of a re-expansion pulmonary edema so that we manage it as such. Okay, so those are the few causes I wanted us to go through. The other ones are like when you have a patient who inhales toxic substances, the toxic substances can lead to destruction of the endothelium of your blood vessels, which we said is also a pathophysiological factor. Once the endothelium becomes destroyed, then you're going to have fluid leaking out of the intravascular compartment. So inhalation of toxic substances. So sometimes you can have someone in an enclosed room and there's vents, and the patient inhales a lot of the fumes. One thing that kills the patient is a buildup of carbon dioxide in the patient, and carbon monoxide, in the patient's blood, because inhalation of smoke itself is coming with a carbon monoxide. Okay. The other thing is there's basically an inflammatory process generated in the airway, pulmonary vasculature, and all that. And once this happens, you're going to develop some form of pulmonary edema as well. So usually you go in, the person is not even bent at all, but just the inhalation of fumes has killed the person, okay, because of carbon monoxide and some form of pulmonary edema developing secondary to inhalation of a toxic substance. Okay, so I think that'll be it for the evening. I'll take questions. I think it might drop soon, so if there are any questions, let's let it come and then we can close for the evening.
Sir.
Yes, please.
Sir, please, is there a difference between the edema and the edema?
Edema and
edema. The one that starts
in
the E-D.
Oh, no, it's the same.
It's just spelling, right?
No.
So why is the spelling like that?
Different.
Doc, let me answer him.
Yeah.
The same way we have
American and one is British.
Thank you.
Thank you very much.
The same way we have center with R-E and center with E-R.
Yes. So we have estrogen and we have
see edema and edema.
Hello, sir.
All questions are welcome. Yes, please. Let your question come.
Please, can emphysema cause pulmonary edema?
Yes, so as a complication, if you have a distraction of the alveoli, as we talked about, you could develop a pulmonary edema. So yes, it can, because there's a distraction there of the alveoli, so you can develop something like that. Inflammation and all that.
Thank you.
Alright, you're welcome.
Question when the chair say yabbing, and yeah, edema. Bruh.
Pressure. All right.
So, Nick, Make bisabi.
Evans, the
Evans Fenimasi, Evans Fenimasi.
So would
It's okay.
Evans, I had CV question, CV,
when we meet in class, we'll try and then discuss other aspects of respiratory system, and then we'll start preparing for exams. So we'll do some few topics in GIT, and then we'll start preparing for exams. Okay.
All right.
Yeah. Please. Have a blessed
Okay,
evening.
sir.
Okay,
Thank
sir.
you.
Good night.
Okay, all right.
Odima, bye-bye.
Obeyamo.